think that thing of it takes 7 years or whatever to diagnose endometriosis, what's actually important is the time it takes to treat and validate a woman's pain.
Welcome to Fempower Health. Georgie here. I'm so excited to bring to you this episode with Dr. Peta Wright out of Australia. And for those of you who have listened to previous episodes with Dr. Lara Bryden, who is actually out of New Zealand, you have her to thank for this introduction. This episode actually was a get to know you call with Dr. Wright, and I had asked her at the beginning if we could record it, and this Zoom call has now turned into an awesome podcast episode. So thank you, Dr. Wright, for your openness and sharing this initial conversation. And here we talk about endometriosis, pain, and also how trauma can impact pain. This is really an initial conversation because we agreed we definitely need to talk more about this topic. So as you listen to the episode, please do share with me additional questions that you may have, because I will make sure to ask them of Dr. Wright in our next conversation, and that episode will go live in season 4. So be sure to follow on Apple Podcast and Spotify Podcast so that you will be alerted for when that goes live. So let's take a listen to this awesome conversation.
So I'm I do fertility and I do gynecology, and I kind of focus in a much more holistic way than the conventional gynecology system kind of does.
Right.
So like often, as I was trained, it would be a woman would come in, just discuss her period problems or her gynecological things, and you kind of have a very quick question about, family life, family history, social history, and then that's kind of it in the typical how I was trained to practice, right? And no basic and root cause, as you were saying, even in medicine conventionally isn't a thing that you focus on. I guess
Right.
it's like you come with a period problem, it's heavy, it's painful, whatever. Okay, so what the conventional solution is generally surgery, or it's hormones, or it's the pill, or it's, something that switches off the cycle to regulate. Obviously it doesn't regulate the cycle, switches off, or removes something from the body. So as a surgical answer, they're only what you're interested in when you're a conventional gynecologist mostly. And I became very, very, very disillusioned by that. And also I think I talked to my patients a lot more, and I could understand the impact that environment have on women's health. So for example, with polycystic ovarian syndrome, which is just, I have a massive bugbear with that anyway, with the name, but it's an umbrella term. No one wants to get to the root cause of it. So it's all just slapping a big Band-Aid on it and women are very confused by that diagnosis as well. And it's so often it's environmental, either environmental at the time or environmental from when the woman was in utero, from environmental exposures early on in her life, but no one was interested in doing that. And I just became very interested in doing that for all of those conditions, and educating and helping women to understand about their bodies. Because like the number of women I've seen who are 43 and have been on the pill for almost their entire lives and have no idea what the pill is doing to them, and they've just gone on it because their doctor has said you should go on it for acne or to regulate your cycles at the age of 14, is crazy. It's so common. And women who now come to see me for fertility problems, who started their period at say 13, had irregular cycles, which is pretty normal when you're first starting to get cycles. If you understand the development of the brain and the ovary axis, you understand that that's part of it. But many GPs aren't educated about what's normal in a woman's body, and so they don't educate women, and they're just like, okay, well, here's the pill. So that they go on the pill before their reproductive systems are mature and before they're regularly ovulating. They stay on it for 20 years. They then go off it at 35 and want to try and have a baby, and their periods are irregular, and they might have acne and they might have some other things, which then they get slapped with a diagnosis of PCOS and get really funneled down the fertility pathway, or the infertility pathway, or having to do IVF to conceive, when really their reproductive system is still immature and it just needs time, which they're lacking at 35, right? So that's a big thing in itself.
By the way, you know, that was me. I was on the pill from when I was 18 to 35.
Yeah, but this is the thing. And also doctors will say that's a really good way to cure or treat endometriosis, which obviously not, because you were on the pill for that whole time and
Right.
you have endometriosis. So doctors telling women that the pill or hormonal suppression is the only way to treat endometriosis is not right either. The other thing that I've found in my research, so talking to women, so I did a big course with Aviva Rom. Do you know her?
Yes, I do.
Yeah, probably a couple of years ago. I feel like my child was little, like maybe 3 years ago, on integrative medicine. And I've done a master's in fertility and all of that sort of stuff. But her course was amazing. Like that was the most amazing, wonderful, eye-opening, beautiful thing, because it taught root cause medicine and it taught wholehearted medicine. And I always say that, and my conventional friends don't have any idea what I'm talking about and think I'm really woo-woo. But like, I think that's so important. So I ask everybody about everything, you know, environmental exposure. Before anyone comes to see me, they've filled out a big intake form, including things like, and this is probably controversial, and I'm speaking at it at 2 conferences, and I'm writing a book at the moment about this somehow between my time, about pain, pelvic pain and trauma. So I would probably say that about 90% of the women who come to see me who have pelvic pain have got a history of childhood or adolescent trauma. And no one really thinks to ask women. And I think it's this kind of, well, there's not enough time in a conventional consult, you can't really get into it. But, and also not wanting to say to women, your pain is in your head, because of course we don't want to say that to women, but there is a connection, huge connection between trauma experienced as a young person or ongoing stress and pelvic pain, in my practice, in my experience, and in the literature as well. So there's a study by Sonia Grover, who's a doctor here in Australia, who it was a systematic review, which just came out maybe a month ago, which was very handy because it cut my book research short because she had this beautiful summary. Have you heard of the ACE study, the Adverse Childhood Event Study?
No.
Okay, so it's an American study. I don't know how long ago it was, but basically they looked at, there's a questionnaire called the ACE questionnaire, and I can't remember how many questions, but it basically gives you a score and it is quantifying childhood trauma. So incidents in childhood, adolescence, pre-18, and it gives you a score. And if you have a higher number, they found in their studies that you were much more likely to have, even when you controlled for depression and mental illness and things like that, but you were more likely to have depression, addiction, but physical things as well. So cardiovascular disease, high blood pressure, autoimmune disease, including pain, because the theory is of the way that, you know, trauma and prolonged stress changes our nervous system. So it creates changes in our nervous system, which then change our hormones, which then change our gut microbiome, which then change our immune system, increase inflammation in the body, to actually have physical changes that can be seen further down the track. There's a link between childhood trauma. We often think sexual trauma, but it's not just sexual trauma. It's also like family trauma, divorce, relational stuff, things like that, or, you know, the family members having health or medical problems during that time of their life. And I see that so often, especially if it's persistent pain. So, you know, someone can come with just painful periods or painful ovulation, and that's sort of, you know, the more simple pain.
A question for you is, in this kind of a case, how does root cause, so we know this is the root cause, right? The trauma, but like now you have the condition. So then how do you tackle it? Like, is it, you have to make sure you handle the trauma?
So it's really important, because what happens is this is what I see typically. So I'll see the people who haven't seen other people, or I'll see, and this is a big part of their, I'll send you some graphics if you like, that might help to explain how I explain it to my patients. So even if someone has endometriosis, and if you talk to Lara as well, she'll talk about the you know, bacterial, like the theory of gut microbiome, leaky gut, like increased intestinal permeability, LPS, going through those gaps, interfering with the immune system, and potentially that being part of what's happening with endometriosis and like other autoimmune diseases. And there's lots of evidence that stress and trauma affect the microbiome, affect the ability of the endothelial cells to make that mucus layer, and then increases the chance of intestinal permeability, right? Increased intestinal permeability. So basically what I say with so I've got like two diagrams. One is like got pain in the middle, and it's got all the factors that contribute to pain, which I think is so important. And so they're things like, so sometimes trauma, sometimes the effect on the autonomic nervous system. So that often increases our sensitivity to pain and prostaglandins and inflammation. The effect on the gut, immune system, increased inflammation, endometriosis, it can sometimes be part of the pain picture. Increased pelvic floor dysfunction, which is a huge part of it that is often unrecognized.
Yeah.
And then the effects of that ongoing. So then, further, when you've got that pain cycle set up, then further kind of isolation, anxiety, depression, whatever, and then it continues. And the other one is a picture of an iceberg, and it's like a big iceberg with its pain, and then at the very top of that is endometriosis. And then there's laparoscopy tackling that endometriosis, which is like the tip of the iceberg. But then you look at the water and the iceberg isn't there that you think, but underneath the water, there is all of the things that can contribute to endometriosis that haven't been tackled. So the increased inflammation, the immune system dysfunction, then the pelvic floor stuff that is part of the pain stuff, the turned up autonomic nervous system that increases your not only increases your feeling of pain, but it also increases your inflammation and reduces your immune system and makes that cycle continue. So if you're just doing a laparoscopy, you're missing so much of the picture for women who have pain and who are, I think, often being told that endometriosis is the only cause of pain, and the only thing you need to do about that is get a diagnosis, get it removed with surgery. I think that's really dangerous, because I see women who've come from other gynecologists who are very lesion focused, and they will have had 10 laparoscopies and they're still in pain. And in fact, they might have come to that first person with either pain just with their periods, and now they have persistent pain because they've become centrally sensitized, and then they've got scar tissue and they've had all of these operations, right? And their pain isn't better. And not only is their pain not better, it's worse, but you then dig down into, okay, well, what are the other factors in your pain that haven't been addressed up until this point? And, there might be trauma that's a part of it, pelvic floor that's a part of it, increased inflammation, all of that, which haven't been addressed with diet, haven't been addressed with pelvic floor physio, the nervous system stuff hasn't been addressed. And in fact, it's just increased and increased and increased because they haven't been able to understand that link between what's happened to them and then how that affects their physical body. Because if you can understand that, then you can be like, oh, well, that explains a lot of what's happening in my body. There might be other factors like endo, which is wrapped up in it, but you can begin then to join the dots and begin to sort of create a plan to tackle the pain in the whole picture, especially with the nervous system stuff, by if there's trauma to address, acknowledging it, addressing it, getting appropriate trauma-informed care. And that might be talk therapy, it might be somatic stuff, it might be EMDR. And then it's about understanding that if your nervous system is turned up to like 10, I always talk about it like being a dial, a volume knob. Yep. And if something's happened to you early in life that's pre-programmed your nervous system to be hypervigilant. So people like Bessel van der Kolk, I don't know if you've read his work. He's written like a New York Times bestseller called The Body Keeps the Score. He talks about, yeah. And so if your nervous system is like dialed up to 10 because you felt unsafe at a certain point in your life, you become hypervigilant, and that then can carry on to your life. So it's about I understand that. I can now do practices to help turn down my nervous system. So that might be doing the therapy stuff. It might be learning to do deep breath work. It might be learning to meditate. It might be doing yoga therapy. It might be getting into nature. It might be catching yourself when you're in a pain flare. Because, for example, the flip side of the women with pain and endo is the women who have pain, who have a laparoscopy and who don't have endo. And I've seen so many women cry like devastated in the recovery room if they don't have endometriosis because, oh my God, well, they're not getting validated. And I don't think surgery should be the thing that validates someone's pain. I think that should be validated when you first see them and they're talking about their pain.
Yeah.
And and often, so when I trained, if you did a negative laparoscopy, so you didn't find endo, you'd be like, oh, well, it's not gynecological. You can go to see a gastroenterologist. Like, it was just given, there was no explanation. And now I have huge explanation for this. If they don't have endo, but they still have a lot of pain, often this is part of their story. And then they can understand, oh, you're getting really bad ovulation, really bad period pain. Well, what happens at these times? You have prostaglandins, you have inflammation. Some people feel a little bit of pain in those times, but yours is turned massively up. And your experience of that is because your body is feeling every little thing as a threat. You know what I mean? So it makes a lot more sense. So that education piece is really important, and then it can help people because if you've had sexual abuse and you've got pain as a result or whatever, one laparoscopy and no recognition of that trauma isn't going to help, and 10 laparoscopies is definitely not going to help. And I would even go so far as to say that even with endometriosis, the evidence for surgery, to speak to the people that are really outraged about suggesting that using ultrasound to diagnose endometriosis is perhaps better than surgery, is I kind of actually question, being a person in the field who has done laparoscopies my whole life, that most people, and even when they've had the best surgery from the very, very, very best person, especially if they've already got persistent pain before they go in for their surgery, there's a good study that says that if you've already got persistent pain and you don't have ultrasound evidence of deep endo, then surgery is probably unlikely to help that much with pain, even if you have endo diagnosed at laparoscopy, but it's mild. And also, there's the paradox of endometriosis, right? There's the fact that a lot of women have endo and have zero pain, and some people have no endo and have pain. And there was a study looking at just doing laparoscopy in women for other reasons, and they found that about 50% of women who were asymptomatic had endo, probably mild endo. And I think that some endo is probably physiological, in that 100% of women have some blood coming back out of the fallopian tubes and into the pelvis when we bleed. And if you've got a healthy immune system, or you don't have too much bleeding, then your immune system is going to clean up those cells. But if your immune system is not working well, so it's dysfunctional, it's overactive, that's when often you get that severe endometriosis and scarring. But, there's lots of anecdotal data about going back and doing second look laparoscopies, that people don't really do that much anymore. But having noted some endo in the right side, and then they go back and they're like, oh, that's gone. And there might be a little bit over on the bladder. And that would be part of a healthy immune system dealing with those cells. And then when you look at the evidence for surgery and endometriosis and pain, which is really why you're doing the surgery apart from infertility, that a Cochrane review in 2020 looking at laparoscopy for pain and endometriosis concluded that we're uncertain whether it's actually an effective treatment for pain. There have only been 3 randomized controlled trials on pain and surgery for endometriosis. And in one of them, I don't know if you know about this one, this was an Australian study. There wasn't that many people in each arm, but they did laparoscopy on everyone in the trial, and they only removed endo in half of the people, and they left it in the other half, but they still did the keyholes. And after that, so it was 70% of women improved with their pain if they had excisional surgery, but 30% of people improved by just having the holes. So the ones that didn't have this actual endometriosis surgery, 30% of their pain improved, initially, which is a crazy placebo effect, right? But it's you're getting validated. And then 6 months later, when they went back to excise the endometriosis in the people that they didn't excise it, they found that like a third, I think 40% was the same. 30% was improved when they were documenting the lesions, and like maybe 30% was a bit worse. But there's basically, I feel like with all my work that I don't know. I mean, I don't think that doing that first laparoscopy for diagnosis, so if it's fertility and there's unexplained infertility, and you know that removing endometriosis can improve your spontaneous pregnancy rate by a bit, but not massively, it's then I would do laparoscopy for that. But telling people that, you know, it's by what order that it can increase fertility. But for pain, I think that as a society, we really, really need to rethink doing surgery on women for pain and having like endometriosis being this big fear point in young women's minds, because all the evidence suggests that it's not that great for pain relief, and it can be making things worse. And there are a lot of other things that we need to tackle. So, you know, looking at diet, looking at stress, looking at environment, looking at other treatments that can reduce inflammation in the body. And I don't necessarily think that a laparoscopy is, I think that thing of it takes 7 years or whatever to diagnose endometriosis. I think what's actually important is the time it takes to treat and validate a woman's pain. That's what I think is important. And I don't necessarily think that a laparoscopy is necessary for every woman with pain.
Yeah.
And I think there needs to be discussed. So I discuss all of that with my patients, and I say, you know, this is what you can, because I have some people who go in, like, for example, I saw a woman the other day who had an ovarian cyst. Mm-hmm. And she had a torted ovary, so it twisted on its blood supply, and she had to have surgery to remove the cyst and correct that. She was like 38 or something at the time, and she'd had 2 children in the past. And so she went in, had that, and before that had some pain with periods, but all very manageable, not anything major. The surgeon at her surgery said, oh, and took her ovary out and said, oh, and by the way, you've got endo, so we're going to put you on Zoladex after this. Like, there's no discussion. It's just, you've got endo. It's like, you've got it. It's like cancer. It needs to be treated, right? Not thinking about lots of people have endo. It's about your quality of life, and you've got to be doing something to improve the person's quality of life, right? But she didn't know. She's like, oh my God, I've got this thing. I've got endo. Oh, okay then. Got put on Zoladex, felt horrible. So that's, you know, turns off everything and makes you basically reversibly menopausal for that time. Yep. Then said, we're going to plan all these surgeries. Then that doctor went on to do 5 more surgeries in the space of like 8 months to remove endo, and also because she kept having a cyst with ovulation, which is probably just ovulation and her pain pathways becoming more and more regulated. Then she went to another doctor who's like renowned for just like operating and treating the lesion. Like, this guy would do, you know, I would see his patients all the time who become broken, who've had so many laparoscopies, put on so much like synthetic progestin to reduce the size of lesions or to reduce pain and bleeding, like 2 Mirenas at once plus synthetic progestin. Then they would get depressed, put on 30 kilos. So he'd put them on an antidepressant, which would increase their awful, right? He's treating a lesion that may or may not have something to do with this person's pain. He's not treating a whole person. And this is like the paradigm, right? But this woman that I was talking about, she then went and saw him. He did a hysterectomy. Then he did an operation 2 weeks later because she had more pain, because she's now got persistent pain all the time, and thought, okay, well, she told me I had a nerve trapped in the vault or something. It sounds like she's having a pain flare. So all of the things like the pain, the pelvic muscles, the nervous system just completely flaring. Went back to surgery, then went back to surgery again like 6 months later because she had some more pain, probably from ovulation from her remaining ovary. Now this woman has pain every single day of her life. Before she didn't, and she's now still bleeding, and he's left a bit of cervix behind, so she's bleeding. Anyway, this is a very big example of why surgery is not benign, and that going down that surgical route when we know that there's a very high rate of recurrence of pain. So what the story is then, that women just need to have 10 surgeries, that still doesn't improve their pain. I totally reject that, and I think that it's causing way more harm for women than good.
You know, when I interviewed Mike Armour, so this is funny. So how I came to interview him is because of that article that was in ABC and the title. But when you read the article, it like didn't make sense with what the title was. And so I asked him about it. And it's interesting because his philosophy is very similar to yours. And he said that unfortunately, to get the clicks, they didn't want to change the title. And so he was stuck because he had control over the article, but not the title of the article. And for anyone who looked at the title and didn't read it, I can see why. And I remember I felt very disjointed because I'm like, the title says one thing, the content says something different. Anyways, he was saying similar to you, which is like, we need to get away from, I think you have endo and let's do surgery.
Yes.
And so I think what he was trying to say is, like, there's all these other things you could do. And if you think it's endo based on these other things first, then there's possible other steps. But he was trying to say, like, it shouldn't be, therefore do a it's more, can we do other things instead? And so, yeah, it was, I'm glad I connected with him to try to clear it up. And I published the episode so that people can hear, like, this is what he actually meant. Yeah. So, you know, it's interesting connecting on this because, like, I'm now trying to figure out if first of all, I almost want to just take part of the segment of what we just discussed and like get it out there because I think it's such an interesting point and a lot of examples, I think, for people to think about and react to. But, you know, it's interesting. Like, I almost wonder if we should talk about this broader component of rethinking pain for women, pelvic pain for women.
I'm writing a book right now on this. Okay. Absolutely. Because this is the thing. I think that women have been, I think the pendulum has swung from throughout time, really, of women having pain and then like, okay, they're just hysterical. It's in their head. They're crazy women, right? And that was maybe a bit what it was like in the past. And then the, I'll just suck it up thing. But also, like, this is a very broad perspective, right? But we live in a very patriarchal society.
Yeah.
So when we have a period, we don't get any, like, there's no understanding. There's no concession. Our world isn't built around us. It's like, it's all about productivity. Like, so when you learn about talking to women about their, for example, period pain, it's like, do you miss any days of school or work? Because we can't have not productive women, right? But I believe that if the world actually acknowledged that women's biology, people born in a female body with female anatomy, it's different. It is not the same as men, right? We have a 28 to 30 day hormonal cycle that's completely different to men. Like, men have got that testosterone's really high in the morning. Yay, that works with our 24-hour clock and the way society's built. It goes down at the end of the night. It gets recharged by sleeping and then it's back up again. Yay, the whole society's built around that. We don't have that, and our hormones are fluctuating throughout the month. And there's no language or understand. I think that's becoming a bit better. And I work in a very, like, an environment that I've built like that. So it's okay for me, but it's not like that in the broader community. And you talk about, okay, well, how about, like, we now, after the pandemic, we know people can work from home and it works, right? So I actually think that the world and suffering with pain would be way less if the world was like, yes, your period's coming, you've got 1 or 2 days where you can work from home, you can be in your own comfortable space. We acknowledge that this is something that's happening in your body and we're not forcing you to, like, continue to do things the way you were 3 days ago because your physiology is different right now, right?
Yeah, absolutely.
And countries that take on menstrual leave and things like that, I think that shows. And anyway, so that's a part of it. So the drive and the pain thing is, all pain is bad. All pain is bad. And as you grow up in a female body, we have this sort of conditioned shame around our bodies. There's the whole body image stuff, it's fitting into like this one size of what is acceptable. There is the shame of periods, of like, it's almost like the body is the enemy. I often think about with women with endo who are very identified with that diagnosis. And I think it's really important for women to have help and support, and that's amazing. But the identification with endo as like the only thing that that diagnosis is the thing that brings them connection, which is all what we're striving for, right? But then that meaning and connection just comes with this identification with endo. And what happens is, in the current paradigm, is that women are sort of painted as their body is so if you think about the victim, there's this victim, perpetrator, rescuer triangle, right? The victim is often the woman who is suffering from pain or endo. The perpetrator is their body, right? Think about that. You're in a war against your female body. And so the only way you can deal with it is to cut bits out of it, shut it down with hormones, turn off anything that is part of that hormonal cycle or female body thing. The rescuer is the doctor or the medical system. And they're in the model where you might have endo, let's do an operation, something external to you, let's remove a lesion, not empower you with any of the other stuff, like at the bottom of that iceberg or that pyramid that's looking at like how you can eat that might support you, how you can reduce your stress that might support you, how you can use supplements and herbs to reduce inflammation, how you might use hormones to reduce inflammation. But that's all empowering you, and it's giving you as the woman the tools to make the right decisions for your health. But the current paradigm is just, in the surgical thing, is let's do a surgery, give you a diagnosis which you can then identify with for the rest of your life as like the enemy kind of, and then it's all about just the enemy is this lesion in your body that's taking over and you have no power. And I think that's terrible. And then like the pain is always bad thing is also terrible. Like, yes, some pain, like most people, 90% of women have pain, some pain with their period day one or whatever. But young girls from the very beginning are like, oh my God, I might have endo. And then in their head, because you can't see endo, they're like, oh, but if I don't have surgery and I don't remove it, it could just like grow. It's like this invisible monster in their pelvis. And it does sound really, really scary. But also there's no understanding. And they're like, oh, but if I don't get it removed, it might get worse. But there's no understanding of the natural history of endometriosis. There are some people, the very minority of people with endometriosis who do have very severe, like deep nodular disease and the endometriomas and the ovarian disease. But the vast majority of people who have endometriosis have that mild superficial disease or one bit, like one lesion. And there's no evidence that if you don't do anything, it gets worse. Like there's no understanding of that, because to do that, you'd have to do multiple laparoscopies on a woman throughout her life. And for a condition that is benign and for a condition that may or may not cause problems, there's no need to do that. Like I saw a woman the other day with an ultrasound diagnosis actually of endometriosis, and she has zero symptoms, no pain, nothing. She just had a scan because she was looking at trying to get pregnant and she was older. And her GP was like, what do you think? Does she? And then she was terrified. Oh my God, do I need to have this? I asked her, do you have pain? Do you have problems with pain with sex? Do you have any issues with infertility? No. I'm like, well, no, we don't need to do anything. But there would be doctors who would go, yes, you need to have that removed.
Right.
Based on no evidence, because it's a benign thing. Even rectal or patch of Douglas disease, they've looked at over time and it doesn't seem to get worse, but I just think it's a really interesting area where women are having their power taken away from them, but they kind of feel like someone is listening to me, someone's doing something about it. But the greater thing is, what is the whole picture of their pain? Like women are blown away when I talk about all the different aspects of their pain, because it gives them, okay, I understand what's happening in a pain flare. I can do this. This is what I can do in my toolkit. Or I'm having like a massive, like the sharp stabby pain. It's probably pelvic floor pain. What can I do? Pelvic floor physio is so important. I can learn to do some releases. It's just, if someone could do some kind of study on whether they never do it, but physio is like 1,000 times better for pain than surgery.
No, I agree. And I'd love for your thinking on this. I'm still stuck on this review that I got on my podcast, and I wish I could contact the person. It was like, I understand what she's trying to do, but I don't listen to pseudoscience. And she's got a lot of natural medicine doctors on her podcast. And it was so interesting because I actually bring on different perspectives, because I believe that given there are, limited research dollars in women's health, all we can go with is what people who see these women every single day are seeing. And yes, I know it's not a randomized, double-blind, controlled trial.
But we have the random, but that
you're right. In some, you're right. In some areas we do, but.
And it shows that the stuff that we're doing in conventional medicine has pretty terrible evidence.
I know.
And we're continuing to practice that way.
I know.
That's an incredibly important thing to get out there. And that's the other thing, like the women who are like, excisional surgery versus ablation, like it has to be excisional, it can't be. The evidence that excisional surgery, I mean, I would always do excisional surgery just because it's safer and it's better, but there actually isn't evidence to say that it helps pain more. So I don't understand the endo community that are getting really, I think women have been disempowered. And I think that as clinicians, and
I agree.
I think I love what you're doing because it's about educating and empowering women because it takes away the fear. Like just one, I'll say one thing before we go get your son, but even something as simple as if someone has some pain around ovulation, right? And it might be more severe for whatever reason. And they might go to the doctor and they'll say, oh my God, you've got a ruptured cyst. Sounds terrifying, right? Terrifying. But then I'm like, and then they'll say, oh, I keep having ruptured cysts and it's terrible. And it's ruptured cysts and my body is terrible. I'm like, okay, when do these ruptured cysts happen? Okay, so I'll just talk to you about another way to explain that. That is your ovary. It's growing a beautiful follicle. It's releasing an egg. And as that little egg pops out of that follicle, it releases some inflammatory compounds which help it to do that. And then some of that fluid goes into the pelvis and might irritate the pelvis and can sometimes be painful. There's a German word for that, which is Mittelschmerz, which means pain with ovulation. But it's just like you're doing amazing things. Your ovaries are doing what they're supposed to be doing, rather than you've got a ruptured cyst in your pelvis and it could explode. Can you see the difference in language and fear, and then how that, and they've done studies on language and using fear-based language to explain things and how if you don't use that language, pain goes down. So that's really important because you're not pathologizing women's bodies at every turn.
Yeah, agreed.
So what you're doing is very important.
Thank you. Thank you. This is awesome.
But this way isn't working. So it's important that we talk about it. Like it's not working.
Everyone I talk to who's got anything chronic, this is the life, and it's irritating.
Exactly. You have a car accident, great. Western medicine's wonderful.
I know.
But chronic, no.
Exactly. This was a pleasure. Thank you so much. I'm really excited to get all this information out. I love the way you think.
Thanks, Georgie.
Okay, thank you. It was wonderful to meet you. Bye-bye now.
Thank you. Bye-bye.
Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find a link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.